Hello, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. Once again, I'm joined by my co-host, Dr. Johanna Richey. Hi, Joe. How are you?
I'm good, Jeff. How you doing?
I'm doing fantastic. Joe, I really enjoyed coming to the lab yesterday with the ankle arthroscopy portion of your
Oh
surgery
man, we're having
course.
so much fun. Yep. The students are teaching
Incredible.
me stuff now. It's
Hey, that's the
fantastic.
plan. There
Yeah.
you go.
Yeah.
All right. Well, we have a phenomenal guest today from Miami, Florida. He is on Dean's Chat for his second time, Dr. Jason Hanft. Welcome to Dean's Chat again, Dr. Hanft.
Thank you for having me. I must have done something right the first time.
Well, we're hoping that there's not going to be a storm that knocks out our Wi-Fi this time.
It's about to happen. It's evening time in Miami, summer, so storms are about to start rolling in.
All right. Sounds good. Well, in Dean's Chat form, let's go with first names, Jason and Joe and Jeff.
Perfect.
All right. So Jason, on our last episode, we touched on your career, we touched on your education, your residency, your fellowship, touched base on entrepreneurial adventures. We talked about patents and other aspects of intellectual property. And we talked about your company, the Defender Operations, and you were getting going and we discussed getting product into place and trying to reach out to the consumer. I was hoping we could continue that discussion.
Sure, for sure.
So
my favorite topic.
I figured it would be. So, and I love following you too on LinkedIn and all the social media, and I hear nothing but good things out in the field about the Defender products. So I'm super excited to have you on. What's the current status? How are you guys doing?
We're doing great. Believe it or not, in the middle of summer, August was our best month in history. So we sold more product and made more money than we have in the last 2 years. So things are doing wonderful. If you remember when we started Defender, the whole onus of starting the company was to build medical devices that patients wanted, asked for, and they could use. So we continue to sharpen that edge and focus on our founding philosophy of making sure that everything we have is easy for patients to use, it fits a need, and it engages them in their care. So
fantastic. Just to give a 30,000 foot picture, Jason, if you wouldn't mind, because a lot of our listeners aren't familiar with diabetic foot ulcers and their impact on not only their lives, but also the economic system in healthcare. Do you mind giving us kind of an overview on that can kind of slide us into specific discussions?
So we'll focus on the US alone, although it's a global disease. 1 in 10 Americans this year are diabetic. In the next 4 to 5 years, that number is going to go to 1 in 3. Of that, 25% have peripheral neuropathy. And those are the folks that end up with a wound. Diabetic foot ulcers in general cost the healthcare system somewhere between $18 and $20 billion annually. It's the #1 reason for people to get admitted to the hospital in the United States for a lower extremity problem. So complications of diabetic foot ulcers are not only costly to the system, but they're the primary pathway to amputation. I think the number is 85% of all lower extremity amputations are related to an infected diabetic foot ulcer. Once you have an amputation, you have a mortality rate in 5 years of 50%. And if you knock out pancreatic cancer and 1 or 2 other rare cancers, that's a mortality rate higher than most cancers. So you're talking about a disease state that affects a huge number of people, has a massive effect on the economy, and has a human effect that's just untoward. I mean, if you sit in a room with 10 people, one of those people is going to have a diabetic foot ulcer.
It's incredible. I agree with you. There was that study that showed a patient with diabetes with a wound, they fear losing their limb more than they fear dying even.
I just did a podcast with Neil deGrasse Tyson, and we were talking with a healthcare specialist who focuses on folks who live a far distance from a hospital. And they brought this up, even though I knew it, but if you're a person of color and you live more than 50 miles from a healthcare system, you have a higher chance of losing your leg than you do of keeping your leg once you have a diabetic foot ulcer.
Wow, that's a sad state of affairs. Joe, your thoughts?
Yeah, and this is where, when I had listened to that episode, Jeff, where you and Jason got to talk initially, some of the profound impact that we as healthcare providers can have. And Jason, what I appreciated so much was your conversation and some of the research that you had done. And, you know, why aren't people doing what we tell them to do, right? It's so easy to stand on the doctor pedestal and be like, bad patient, you're not listening. But when you really stop and you ask people, especially the statistic you just talked about, like you live this far from a healthcare facility, we know how that's going to impact your outcome. So what is it that's getting in the way? Can you help me understand the why? And for the patients, they don't always know to flip that narrative and say, okay, doc, you want me to do this thing. Help me understand the why. But even when they do, sometimes the why is like, there's no way I can do that. What you're asking me to do is impossible. So I'm not going to tell you I can't do it because that makes me feel shameful. I'm just not going to do it. And I really appreciated the conversation you guys had. Can you touch a little bit on, I love that you just had brought up the engagement part of helping patients have the tools and the resources to be a part of their care. Can you talk a little bit about that?
Well, let's go a little deeper, Joe. I think what I've learned trying to focus on this is that's the first step. The second step is trying to understand where some of these groups, populations are coming from. So if you look in the South and in people of color, you have 4 generations sitting around a table on Thanksgiving with at least one person in each generation missing a leg. It has now become an accepted outcome to their life. Once that happens, instituting care becomes an even greater challenge, right? So if every day you wake up and you can't see out of your left eye and everyone around you can't see out of their left eye, there's no reason to seek care. That's a normal condition. Same thing when 4 generations, 3 above you, have got a wound and the outcome to that wound is an amputation and they've lived with the amputation, seeking care is no longer sought. So we have to start there, right? And that's a very big education piece as a country, as a medical system, we failed on. Then the second question comes, okay, if we can engage that group of risk that are at the most risk, how do they get care? And what you begin to find out is in rural areas, in low income areas, they don't.
Yeah.
And then the question falls on us as caregivers, how do we deliver that care? Well, I think COVID opened our eyes to remote care, or at least part of our care delivered remotely, or mobile care, or right. So these are the sort of things that we're just starting to learn how to use, how to integrate in how to engage the patient in their care, right? You can say, hey, this is the best thing for you. But if it's foreign to the patient, if they don't have access to it because of socioeconomic reasons, because of distance, because of religious reasons, or because of it's just not done that way.
Yeah.
So if every day of your life you knew you were going to get a wound and the outcome of a wound is an amputation, you wouldn't expect anything different. So I think it starts with that education piece. Then how do we, and I think medical corporate has failed. I think the government has failed. And I think practitioners are just starting to become aware. So we can't really fail because we weren't aware of this disconnect. So corporately, we are trying to create a platform by which every person with a wound can learn, can be engaged, and can remotely get products that are easy to use and can help them heal. And this all sounds, pie in the sky, esoteric. But if you take a look at the numbers, The average wound healing rate of a diabetic foot ulcer in the United States in 20 weeks is 38%. So that means 64% of the wounds aren't healed in 20 weeks. So we're obviously missing something. The technology's there. I mean, Jeff's product has been on the market, what, 22 years?
Yeah, the Medicast, and then I think it was 2008 for EZcast, so that's 16 years now.
Right. So contact casting has been around since the 50s. We know it's successful. How many people are getting casted? We're lucky if it's 5% of those who can. Our estimates by our data is 85% of the diabetic wounds being treated in wound clinics aren't offloaded at all. They leave in the same shoe they came in. And these are people that are being treated with tens of thousands of dollars worth of advanced treatments, tissues, bandages, etc. But they still walk out of the clinic in a shoe.
Yeah.
So we're aware as a company and personally that the system's broken. And it's not such a delivery, it's an access to it and an access to the knowledge. So we have gone from being a product company, selling our products, which we think are better and are scientifically better and easier to use, to we want to be able to be a platform for folks with this disease.
Hi, everyone. Welcome back to Dean's Chat. We had a little technical difficulty last week, and we're all back. Got the band back together for the rest of the discussion on Dean's Chat. Dr. Jason Hanft is with us. And when we left off, Jason, you were talking about Defender Ops and how you were going from a product company to more of a platform company for the diabetic foot ulcers. And then you were also talking about how we had to realize that a diabetic foot ulcer is just not just a one-time occurrence in most patients.
Sure. So let's back up a little. Part of the reason for this, what appears to be a pivot, but was really our direction all along, is twofold. Number one, when you have a disease, I don't know, let's say cardiac disease, our healthcare system is pretty refined. You go to the cardiologist has a playbook or a standard of care by which they follow. And pretty much if you go to a cardiologist in Minnesota, Phoenix, or Miami, it's a similar playbook. Unfortunately, in diabetic foot ulcer care, there isn't a diabetic foot ulcer specialist. So the patients end up with their primary doctor. And in a lot of cases, the primary doctor doesn't treat wounds, and they get a prescription for an antibiotic and a referral to the vascular surgeon. And the vascular surgeon does their eval and says, you don't have a vascular problem, go see my friend, the podiatrist. Well, his friend, the podiatrist, isn't a wound specialist. And he says, yep, this is a diabetic foot ulcer, go to the wound center. And at the wound center, depending on the day and the doctor that's there, you might not get someone who can tell the difference between a diabetic foot ulcer and a venous leg ulcer. So there isn't a specialist nor a community focused on the care of this disease state. And let's face it, it's a disease state. And the statistics are pretty clear. Even though you can get epithelium over the wound pretty simply and directly, you haven't cured anything. The patient's still neuropathic, the patient still has a mechanical dysfunction, and is still at risk for another wound. And depending on what literature you read, it's usually somewhere between 5 and 7 incidences in a life. And that's also a driver. So we have the lack of coordinated care, multiple incidences that typically go poorly. I mean, the average healing rate of a diabetic foot ulcer in the US is right around 40% at 20 weeks. That's just abysmal.
And those are patients that should heal, Jason, with adequate blood supply and no infection.
Right. Those are people who've already been identified as having, that's from randomized multi-center clinical trials. So these are people who should be going on to healing, not the challenging ones that don't have adequate blood supply, have underlying metabolic disease and bony deformity, et cetera, et cetera. So if that's the average, where's the fault? And as you and I have talked about a million times, and as Joe will find out, when I was taught very early on, when there's more than one answer to the question, you're not asking the right question. And the right question comes from the patients themselves. So we asked them, why? And they said, no one tells us what to do. I'm guilty of this. I saw thousands, hundreds of thousands of patients. We get their wound healed. See you in 3 months. Go back to your endocrinologist. They had no pathway by which to get care. And maybe if they're lucky, we were attentive and said, great, your wound's healed. We transition you in a device so you get good skin tension. Let's get you in some extra depth shoes with insoles because you're allowed to have that, right? That's allotted by your insurance. And they show up at an orthotist office who's never seen them before, 9 weeks later, if you're lucky, and get a pair of shoes and 3 insoles, and someone says goodbye. And here's a patient that has no medical training, has no feeling, and really doesn't want to take care of themselves, who's now supposed to take care of their feet all by themselves. So this is the impetus for the diabetic foot ulcer platform. We want to provide a platform by which all the needs of these people with a disease state, diabetic foot ulcers, can be met. And with the success of our smart boot, so the foot defender with the Sensoria sensors and the cloud dashboard, we can not only engage the caregivers, but we can engage the patients in their care and in their follow-on care, right? So once their wounds are healed, they'll transition to, and surprise, surprise, we have products for every step of this, right? So we get you healed, then we protect you in our Cloud 9 protective shoe till your skin tensile strength is normal. And then our line of smart shoes and insoles are available. And we can tell you, look, you've taken 50,000 steps. It's time to swap out your insole. You don't need to suddenly become a biomedical engineer to figure out, have these materials failed?
Jason, let's talk about that Sensoria feedback technology.
Sure. So Sensoria makes the most accurate activity measuring sensor in the world. Right now, it's 98.8% accurate in measuring activity. It does that by a combination of gyroscopic and GPS simultaneous tracking. So much like an Apple Watch. But Apple Watches are in the 70% accuracy range. The Garmin watches are in the 80% range. Some of that has to do with the fact that they're on your arm and you can walk without moving your arm.
Right.
It's really difficult to walk without moving your foot, and our sensors are on the foot. So some of it has to do with that. Some of it has to do with the focus of what the sensors are for, right? The activity measuring is a secondary or tertiary key point for those guys, where it's our primary point. Then it reports to the Microsoft Azure cloud and to, right now, Android Watch. And the Android Watch is our link to the platform. So we can, through machine learning and algorithms and a little bit of AI, we can tell when the watch and the boot are separated. So we can now measure compliance.
It's like an advanced version of Armstrong's pedometer study.
So this is the 21st century pedometer.
Right.
Out the response being you, me, and Dave picking up the phone and calling the patient, to the watch saying, hey, you're not wearing your boot, put it back on.
Right.
And one of the beautiful things is you can set thresholds on the cloud and say, hey, if the watch and the patient are separated 10% of their activity time, give them a reminder, send them this reminder that says, please put your boot back on. We notice you're not using it. You can also engage them in, are you taking a shower? We see you're not using your boot. If you're going to sleep, please turn off your sensor so your boot doesn't keep tracking you.
Interesting.
So you can engage them on many levels. You can also have alerts sent to the EMR of the caregiver. So if Dr. Hanft is a really non-compliant patient, and this week I haven't worn my boot 50% of my walking time. Dr. Jensen gets notification, hey, you might want to call Dr. Hanft and get him in here. He's doing a lot of walking without his boot. And in between those extremes of, hey, good job, you're using your boot, to the doctor's going to be contacting you, we can send not only text, but emojis that say, hey, smiley face, you're doing a good job. Or frowning face, you're not on plan.
Poop emoji.
Well, frowning face is what we're using at the moment. But these engagements, we all believe, I mean, it just sounds right, right? It's logical that this would improve outcomes. But Armstrong's group at USC now has statistical evidence that's actually significant that shows if you engage the patients through our system, the outcomes outperform irremovable devices. So we compared it to a non-removable cast.
Sure.
So for once, and you know this data as good as anyone, irremovable devices not only are mechanically superior, but also take the patient out of the equation. Well, now, if you bring the patient in the equation and engage them, we now have data that shows this improves outcomes. So now's the time to provide a platform for these people who are engaged to not only help them with their wound healing, but allow them to have access to those things that they've told us, we don't want to deal with this. I don't want to know that it takes 28 days for my skin to develop enough strength so I can wear shoes. I want you to tell me.
Right.
I want you to tell me when I need new insoles. Oh, and by the way, I need a cream to be an emollient so I have good water concentration in my dermis so that I don't re-ulcerate.
Right, right.
I haven't inspected my foot in 48 hours, but my watch just told me to do it.
So I have a question for you. Back in the day when we did the extra depth, extra width shoes and 3 insoles, we did a survey of all the patients we'd ever healed and put into shoes and insoles. And we found that their recurrence rate was directly related to whether or not they wore the shoes 60% of the time. But you're taking it a level further. You're not looking at re-ulceration. You're actually looking at the healing rates. So my question, Jason, is can they get by?
Prevention.
Okay.
Right, and prevention. So
when they're healing, can they get by not wearing their boot X% of the time? I'm curious about that because it seems like every time they step on it, they traumatize it more, you know?
So in a perfect world, 0 force over 0 time equals highest possible outcome, we think.
Right.
We just submitted an SBRI to examine whether part-time in a slightly less constrictive product, and this is our Cloud 9 protective smart sandal. If transitioning from time to time in something that's protective but allows more activity affects outcome. And we've also engaged in a quite complex mechanical study to find out if 100% is necessary.
And we didn't even talk about this beforehand.
No. So you and I, unfortunately, after all these years of working together, we think alike, which is tragically sad, but nonetheless fun.
Yeah. Joe, what do you think? This is outstanding.
Yeah, well, and I think the other, to your point earlier, Jason, where you were talking about, the patient will start getting alerts at a certain interval, like, oh, you're not using your boot. We've noticed 10% of the time you're not using a boot. As a consumer, engaging patients without annoying them and making them want to disengage from the product. And so helping define kind of what those key boundaries are, like, hey, 10% of the time, it's actually okay if you're not wearing, I'm speculating, but this is the threshold. We've noticed you are exceeding this threshold, please check your foot, or however you describe that. Go ahead.
Right, so in any situation of unknown science, we always go from what Jeff said, 100% is the answer, right? You can't touch your foot to the ground. This Paul Brand taught us, right? Got to do this all the time because we can't manage the forces. To analyzing and figuring out what's the real physiologic response to small amounts. Even more importantly, and I'm a wound healer, It's in my DNA. Even more importantly than healing wounds is what Jeff said. These shoes after wound closure. Okay. How do you get people to wear them? Well, the number one response we got was, I won't wear that because it looks medical. So our shoes look like regular dress and sport shoes with a little bit of extra toe box height, a little bit, the big, other than our, one of our many patents is we invented a way by which to make boots, braces, and shoes that the offloading material is less than 2 millimeters away from the ground. So you no longer need 6 inches of outsole to get enough padding, cushioning, to have effective offload. So essentially, you take a cup sole shoe and router it out to 1 millimeter thickness and insert our proprietary insole, and you have what you could, I mean, I wear my prototypes to every meeting I go to, and no one knows that I'm wearing a diabetic shoe. It looks like a wingtip diabetic, men's dress shoe.
That's awesome.
So the engagement part of utilization is two-pronged. Make a product people want to use instead of look at and go, over my dead body, literally. I'm not going to use that. And they're smart enabled. So they have the same sensor that reports to the watch and to the dashboard that we can tell them, you're not using it, put it back on. Or, hallelujah, you used it. Well done. Here's some free skin cream for doing such a great job.
There you go. I think that's fabulous. I all of a sudden I'm having some flashbacks of patients in another life when they would look at me. One in particular would say, Dr. Jensen, I'll wear those shoes if you wear those shoes. They'll kind of try to negotiate. And but you know what I mean? You're right. Nobody wants to look medical. They don't want to wear heavy shoes. You're onto something, Jason. I love it. Great work.
So we think that making great products is super important, and being a good product company is absolutely essential, because you could have the best tech in the world. Much like my first design for Foot Defender, which looked like an exoskeleton that went above the knee. With this tech, that would have been a better offloading device than our current commercial product. But nobody, 0 out of 100 patients we showed it to said, yeah, I'll wear that. So what good would it do?
Good point. Jason, as you bring that up, I mean, I remember working on Defender with you 8-9 years ago, and maybe it's a good transition point to say there's no such thing as an overnight success, because I've watched all the iterations you've gone through over the years. What does it take to get something like this going, and besides persistence and grit?
Depends on how smart you are. And since I started at the lower end of that number, it took us 39 iterations to get to a commercializable Foot Defender that worked mechanically, could be fabricated on a shoe assembly line, and patients would use. So, people talk about minimum viable product as the tipping point to whether you should go to market or you shouldn't. In medical devices, minimum viable product prior to Defender was measured as, can it do the task you're asking it to do? Well, you and I know how to create devices that offload very, very well. But even with the best cast in the world, only 2% of the people are using it. So the real question is not only can it do the task it's targeted to do, but will the end user, and in our case, that's the patient, not the prescriber, use it? And that was something that took me 30 plus years of clinical practice to learn.
Absolutely.
I have a piggyback question on that.
Sure.
I'm curious in terms of so as you are building your ideas to create a product, how do you start to triage what you start doing first, or like how do you figure out that sequencing?
Gosh, I wish I knew the answer to that, because so we created a number of products that go inside a foot defender. So there's 9 patents associated with the boot you see. One of the original first patents we created was an offloading heel device, because we knew we had to take pressure off the heel and we had to take pressure off the forefoot for diabetic foot wounds. So we created heel defender. So I thought, wow, first created, first to market. It's a little more complex than that, right? What is the market for offloading heel orthotics? What are the margins? Who's buying them? Is there a medical code for it? So I think, to answer your question the best I can, it's a really, really complex decision. And many companies choose incorrectly and go out of business before the rest occurs. I'm not convinced myself and Defender still have made the right choice, with Foot Defender being our second product. Turns out the durable medical equipment market is extremely fragmented, in a massive state of flux, ignored by all 3 engagement points. Patients ignore it, prescribers ignore it, and distributors ignore it. So I'm not sure that I can answer your question, because I don't know that we made the right choice. I mean, we have 5 other patents, all of which may have been better choices first. But if you don't pick something and carefully test it, you don't know. So I don't know that there are many people alive who have enough experience commercializing products and developing products that could say, this is the one. But you can test market it. You can go to market with small quantities of assets behind it, so that you don't bankrupt yourself, and can make multiple shots to find out. And a light bulb that runs on direct current wouldn't help anybody if there are no direct current electrical outlets in the world.
And I think, to your point of engaging the patient in part of that process, because you could spend a ton of time and resources developing a product that isn't going to get the use that you're looking for, is a really important one for people that might be interested in doing something similar in terms of entrepreneurial type adventures. When you first started, I remember the podcast with Dr. Jensen, where you two had talked about some of the studies that you had done, asking patients, like, why aren't you doing, what we asked you to do? And the patients essentially just said, I just can't, like, what you're asking is unreasonable. So as you're developing something like a product, at what point do you start eliciting feedback or engaging for, like, commentary, but
Test marketing is
test market. Yeah. Okay.
That's the term of art. And the answer is as soon as humanly possible.
Okay.
Because the direction may unfold to you from, in our case, what the patients told us, right? I mean, although it took us 39 iterations, if we would have followed my course of action, aiming for that 100% offloading 100% of the time, we would have gone out of business. But the moment I showed our exoskeleton to 30 or 40 patients, and universally the response is, I can't and I won't take my leg off. So wait a second, we're missing something. And it's much easier in iteration 3 to go back to the drawing board than it is in iteration 30. And along the way, you may find things that actually help you build your brand. I didn't think of making an outsole such that the material could be closer to the ground and more normal than current shoes. When we asked patients about their shoes, it was the #1 thing they told us. So, okay, how do we fix that? Well, the big problem is, in order to get all that stuff in there and still have toe box that meet guidelines and space for the foot, you got to make room somehow.
Absolutely. Jason, I want to talk about risk tolerance again, but I was wondering if you would share a generic version of the story with the shoe company that you invented an insole for. Generically, not pointing fingers, but it's one of the most amazing entrepreneurial ventures lessons that anybody could hear. Yeah, I just think, if you're willing.
I'm more than willing. I'm proud of my mistakes.
That's not what I'm getting to, though.
I have paid for my errors over time, and if it can help somebody, great. So as most, I've been a eager inventor most of my life, even before finishing residency. And I was able to connect with a group of material scientists, and we invented a material that was exquisitely efficient at reducing impact force. And it was a polymer of an existing material that was used in the glue business. And to give you a scale, products, open and closed cell foams, weren't anywhere over single double-digit PSI reduction for impact force. We were in between 97 and 98% reduction of impact force with our material. And we thought, oh, I mean, the champagne bottles were popping. And we could commercialize it. We could make it here in the US. We had no trouble with it. So we thought that every shoe manufacturer in the world would be interested, because why wouldn't they want the best force reduction in their shoes so people would buy more of their shoes? Well, it turns out there's a lot more to that. And this is another story, but Walmart is the #1 shoe seller in the world. They sell more shoes than anyone. We met with them, went out to their headquarters and sat through 3 days of torture. And on day 3, I got the come to Jesus discussion. You do realize that we spend 34 cents per pair of shoes in materials costs. I turned white and nearly passed out in my chair because our little dollop of shock absorbing material costs 50 cents. So the first lesson there is you need to understand your market before trying to sell into it. Then the second lesson, we did find a multinational big 3 sportswear company that at the time was the most popular distance running company in the world. And they loved the product. They even gave it a name and trademarked it. And we had a agreement that appeared to meet the typical standards of law at that time. And this was a licensing agreement. So understanding the options for exit is also important once you invent something. So the licensing agreement was a small upfront check, followed by a percentage of every product used in every pair of shoes. And again, some of us bought homes because of the windfall we were going to get from this. And the shoe manufacturer then took our technology and put it on a shelf. And they took the name they gave for it and suspended the trademark and put it on a shelf until our licensing agreement expired. And then every pair of their shoes, still to this day, has our material in it, and we don't make a penny from it.
Hello, everyone. This is Jeff Jensen. When we were interviewing Dr. Jason Hanft, it became very evident that we wouldn't be able to cover all the different things we wanted to talk about in one episode. So we are going to cut this episode short. We will be back with a part 2 of this episode, and we will continue to discuss with Dr. Hanft the entrepreneurial experiences of a podiatric physician. Thank you.